Good afternoon. I'm Amy Beckrich, RPA's Project Director. Thank you for joining the RPA Policy Advocacy Leadership webinar on best practices for transitional care units. Before we begin, a few housekeeping notes. All lines will be in the listen-only mode during the webinar. There will be a Q&A session at the end of today's webinar, and you may submit your questions at any time using the Q&A feature, which should be at the bottom of your screen. Please do not use the chat box to submit your question, as they may not be captured. We also have a series of feedback emojis you can use at any time. We are recording today's webinar, and it will be made available on RPA e-learning in the coming weeks. And we will also make the slides of today's webinar available. The RPA PAL webinar series is sponsored by an educational grant from Amgen, and please check the RPA website for other upcoming webinars and events. I also want to take a moment to tell you a little bit about PAL. It is our regional and grassroots focus program. We offer a series of webinars throughout the year, as well as an annual forum each June, which we hope to see you at next year in Washington, D.C. We're really designed to be a forum for discussion and exchange of ideas. And in that vein, I'd like to turn it over to today's moderator, Dr. Catherine Kwan.
Thanks, Amy. Appreciate being here. Thanks, everybody, for joining us. I'm really excited to learn about transitional care. This is an area that I don't know very much about, and it's one of the things I love best about my participation with RPA is the chance to learn from terrific nephrologists and practice administrators all over the country so that I can bring best practices to my area. So I'm excited to introduce our three speakers to you today. We will be taking questions in a group format at the end of the talk. Our first speaker today is Dr. Brendan Bowman. He's a board-certified nephrologist with a clinical focus on end-stage renal disease and critical care nephrology. He currently serves as co-director of the renal physiology course at the University of Virginia School of Medicine. He's been the medical director of the 12-clinic UVA outpatient dialysis program since 2017 and is co-director of UVA's inpatient dialysis unit and critical care nephrology program. His research interests focus on the application of information technology and process improvement to improve the care of patients with kidney disease. Dr. Bowman served as the inaugural medical director of UVA's Transitional Start unit. Brendan, I look forward to hearing what you have to say for us.
Katie, thanks so much for the kind introduction. I want to thank RPA for the opportunity to speak today about a topic that's near and dear to my heart, and for the opportunity to present with my two great co-panelists today, Suzanne and Prayas, who we've had a chance to get to know a lot about each other's programs and share. So this has been a great experience for us as well. So I think my role in this is a little bit to set the table about the background about transitional care and why this has become a bit of a hot topic. And in another version of this talk, I say it's back to the future. A lot of these ideas have been around for a long time. And so what we're really trying to do with transitional care is bundle some proven interventions for patients in that incident period of dialysis and put them together kind of under one kind of metaphorical roof down here to apply those interventions in a meaningful way. So, the group that probably benefits most from this are our new patients, and particularly our crash start patients. And I like to call this rescue therapy. Really well prepared patients do very well. There's lots of research out there to say that they have a mortality benefit. They pick different modalities. They have easier and more rapid access to transplant. But for our patients that are inadequately prepared, they really need concentrated, focused education and preparation for what is really a life-altering change into kidney disease. We're going to talk a little bit later today about the Humber River Hospital experience and their medical director, Dr. Hertz, who has an excellent editorial called The Trauma of Dialysis Initiation in C. Jason from a couple of years ago. And it really gives a great perspective on, psychologically what's happening and how patients are feeling at the time when they enter dialysis. It's a very challenging period. And so it makes a lot of sense to put a lot of effort and intervention up front to support these patients. So when a lot of us think about a transitional care unit, we're typically thinking of a physical space, a location. Either we're building, a new unit, or we're designating a portion of our old unit. But these concepts and these practices can be taken to the patient chair side for your incident patient. So it can be kind of a virtual TCU, if you will, just as much as a physical TCU. It's really about empowering the patients to allow them to make informed choices, not just choices about that modality. And too often, we're offering patients choices without giving them the necessary preparation or background to make a truly informed and empowered choice. And so we think here that transitional care programs can improve that patient empowerment, increase dialysis, and home therapy uptake in general. And with the addition of case management or care navigation services, you can potentially expedite transplant access and other associated similar referrals that are necessary in that beginning. So do we even need transitional care? Why bother? Why is this kind of coming back, after it was first started in the 1970s and 1980s? Well, this is just a different way to see something that's been in the USRDS every year, which is that portion of patients that receive pre-dialysis nephrology care. And the green and the blue boxes represent data on the 2728 form that said either they received none or it wasn't known. The dark blue box down here shows patients that receive 0 to 6 months. And what you can see is across all age ranges, in general, the amount of pre-dialysis care received is fairly low. If you look at patients with either none, unknown, or 0 to 6 months, that's 50% of our dialysis population, starting with really a small amount of pre-dialysis education, okay? And we're saying maybe 30% to a third really have none or unknown, and almost always that translates to none. So I think we would argue that a lot of our patients are coming in unprepared or underprepared. So just because a patient was taken care of by one of us doesn't mean that they were well prepared. And we all have to take some ownership of that issue, but we also need to have the proper support on the back end to hit the holes that we missed in our pre-dialysis care and CKD clinic. This is a similar graph, but broken out instead by cause or etiology of ESRD down here. I want to just draw your attention to this. This is diabetes, this is hypertension, this is GN. All of these share some common attributes of it's challenging to pinpoint exactly when that patient will start on dialysis and when we should start pre-dialysis education so that it's not so long from the time they start dialysis, they forget everything, but not too late. One disease where we do a great job is cystic kidney disease. And really what stands out in cystic kidney disease is we have a long lead time. We know roughly how soon our patients or how rapidly they're declining, and we know when to target that intervention, so it makes a lot of sense. So in these cases, they come into our program, there's not usually a terribly late referral, and we have the opportunity to tackle that problem. And that's an advantage we have really in this disease process. But you can see across the vast majority of causes of ESRD, we struggle with this. So I would argue that when we know exactly when a patient starts dialysis, we as nephrologists do a really good job, but that's not too common. This is the ESRD education benefit or the pre-dialysis kidney disease education benefit and Medicare claims data, again, sourced from the USRDS 2020 annual data report. Less than 1%, okay, are at least billing for this. Now, I think all of us know that we're educating and working to educate a much higher percentage of our clinic population than this, but yet, it's not showing up in claims data. So at least, and this is 2013 versus 2018, we haven't seen it. Now, there's lots of problems with the kidney disease education benefit, particularly that it was limited to CKD stage 5. But nonetheless, not a lot of data that we're doing as much education as we can. So why else do we need transitional care? Well, I think it's important that we recognize that the incident dialysis period represents a particularly expensive and hazardous, dangerous time for dialysis patients. Again, looking at USRDS data about the incident US dialysis patient, this is mortality per 1,000 person years. And all you need to do is pay attention to the graph to notice that mortality is highest in these first 1, 2, 3 months after dialysis initiation. It then starts to rise slowly, but the prevalent population, looking at a couple of different other data sources, incident patients don't really get to the rest of the prevalent population, that kind of 14, 15% mortality per year, until month 6 or 7 after they've started dialysis. That's when they start to come in to a period where they are stable at that point. Really high rates. If you look at this another way, it's about 20% risk in those first 2 to 3 months of dialysis for mortality. That's really, really high, of course. And that means that that's a great place to do an intervention. What about costs? Well, because the peri-dialysis period is often accompanied with a kind of index admission, the costs here, now this is 2010 USRDS graph here that looks at both the Medicare population and a younger population, but both you can see in the peri-dialysis period, 6 months before dialysis, 2 months before dialysis, right around the dialysis period, volume overload, AKI, et cetera, pushing someone into ESRD. These things are very expensive, these admissions. And everyone knows, certainly doesn't need to be told, that prevalent patients are very expensive, but incident patients are the most expensive at the beginning. And it's not till many years till they reach that number similar to what prevalent patients would experience. So this represents a great place for an intervention. It's very expensive and very dangerous, and putting resources on the about 130,000 patients that start dialysis every year probably makes a lot of sense. So why is it so difficult? Well, we alluded to earlier that it's difficult to pinpoint that. Now, I know at the time of actual ESRD onset. Now, recently, there's been more and more equations coming out predicting progression to ESRD. Most of us are familiar now with the kidney failure risk equation, but as you know, that gives you a 2 and a 5 year window. A lot of our ESRD education programs, pre-dialysis education programs, are in a much shorter time frame than that. So you'd love it if you knew the exact date a person was going to be on dialysis. So how hard is that really? Well, in the US, it's kind of tough to look at that, right? Because our dialysis databases and data sets don't always communicate with our pre-dialysis data sets. But one area where that works pretty well is in the Veterans Administration. And this is data from the Veterans Administration on about 20,000 patients in the 12 months preceding dialysis. And what these authors showed is that about 50% of patients had what they call a fast slope or rapid loss of GFR. Now, I think in plain English, that's acute kidney injury on existing CKD. We see that a lot. But these are the patients that unexpectedly transition to dialysis and don't give you the lead time you need to adequately prepare them. So I would say that as we move towards better and better pre-dialysis education, particularly as we're entering the AAKH, the alternative payment models from CMS, a lot of us are doing a much better job upstream. But this problem is not going to go away. Those models help us. Perhaps they delay onset of end-stage renal disease or end-stage kidney disease, but we're still going to have this problem of patients suddenly transitioning to dialysis. That crash start population is not going away because of these alternative payment models, and we need to have a mechanism to deal with them. So again, this is not a new idea. So all three of us are standing on the shoulders of others who have seen the importance and the benefit of this kind of approach. A lot of us are familiar with Dr. Eschbach's work at Northwest Kidney Centers, but as one of the original folks demonstrating the efficacy of erythropoietin. But above and beyond work with anemia, Dr. Eschbach was also the first medical director of the Dialysis Orientation Unit in Seattle, which now happens to occupy the space that's now the Kidney Research Institute at University of Washington out there. So kind of a nice handoff from an innovative program to the next stage of innovation. So back then, the physicians at the Northwest Kidney Centers and the nursing staff there recognized that patients were going more and more to in-center hemodialysis, and to provide a backbone and the education to go home comfortably, they designed this program, the Dialysis Orientation Unit. And a lot of these key components are familiar to us today. And a lot of that means let's welcome all incident patients in here that would benefit from the teaching. All right. And let's make a dedicated team. Let's pick out the best educators in our units already in our program. And let's have a high teacher to patient ratio. Okay, so 1 to 2 nurse to patient. All right, so what we would say in medical education, kind of learner to student or teacher to student ratio down here, and that worked great. Their goal was to increase home dialysis and comfort and the total rehabilitation of the patient, including returning to employment. So how did they do? Percentage wise, they did fantastic. So patients that left this 2 to 3 month program overwhelmingly went on to home dialysis training, where they then proceed to a home dialysis program. Limited care in this sense is an early version of in-center self-care. That's the next most common. Very small number of patients went to traditional in-center self-care. Now, it's tough to compare apples to apples because the patients of 1981 are very different from the patients of 2021. But nonetheless, these were pretty remarkable numbers even for that time. Let's talk about that example at Humber River Hospital too as well. It's hard to find a lot of hard data on transitional care units. And the reason why is a lot of this work lives in the quality improvement domain. And it's not necessarily the kind of typical hard research that we might see in our journals. Nonetheless, there are several abstracts, and I've picked out one that I think is similar and has similar experiences to those of us on the panel too. This is Humber River Hospital in Canada, and the Canadians have really been doing a lot of this work. When the Dialysis Orientation Unit closed the Northwest Kidney Center, that concept was not being used very much. And then in the 2000s, several Canadian programs opened up around the country. And this is just one good example that's under the stewardship of Dr. Hertz. But here, all incident patients not going to the home unit would go through the transition care unit. Now, they call it the transition care unit, not the transitional care unit. But a remarkable 56% of patients that went through the TCU selected a home therapy. Patients that were in a regular unit that went directly there selected a home therapy, and only 20%, 1 in 5. So really remarkable difference. Even more impressive, the crash start group of patients that had no pre-dialysis education and had a sudden onset of ESKD, 50% still chose to give home dialysis a try. Those are pretty remarkable numbers. And I think that 5% in the crash start group that ever go to home dialysis in the standard one is very similar to our experience here in our units too as well. So what are some key elements of a transitional care unit? Well, these are the big three. You need patients. And I'm going to set up Dr. Taylor here. I think is going to answer those questions a little bit later. But who are the patients? You have to have patients, but you need to decide who is going to benefit from this intervention, because there is, a labor component down here. We've got to work pretty hard. How many new starts a year do you have in your program? How many of those patients would actually benefit from the intervention? When we think about the educational curriculum, what are you going to teach? You probably have a playbook that you welcome incident patients with. You may provide this information, but do you directly teach chairside with these patients for 30 to 40 minutes each dialysis session? So do you have a curriculum or some educational materials that you can use to do this? What are you going to teach from so that all of the participants in the program, all the staff teachers are going to work from the same playbook? Who are you going to use? Staffing is tight. Goodness knows right now is a historically challenging time to staff dialysis units. But does a dedicated team make sense? Or are you going to have rotators coming through there? Or are you just going to pull who you can when you can? Who are your essential staff versus your optional staff? So these are all the considerations you want to be thinking through if you're planning to open an intervention like this in your program. This is just a typical process flow. This is the one we use here when we talk about our program, but it's pretty generic. What you're seeing is that an incident patient starts in the transitional care unit, and our place, the Transitional Start unit. There's a 4-week program. Some places are 6, some places are 8. There's a curriculum that we all teach from and coach patients from. When that's over, at the end of that week 4 or week 5, we have the option to extend it a couple of weeks. We have a TSU. For us, it's a Transitional Start unit, but for you, a TCU graduate that comes out, we give them a little certificate, give them a cap and gown, get a picture, and then we have a defined plan. This patient is going to move to home training. This patient's going to move to inpatient dialysis. And now we offer in-center self-care for the last 2 years, and you can do some training there too as well. So this is just kind of a generic process flow of the outcomes we want. Just for a second here for my last slide, I want to talk about transitional care and the Advancing American Kidney Health Act. There's a number of metrics where transitional care can help you augment what you're doing on the front end in your CKD clinics too as well. As we said, there's a lot of patients that will be rolled into this that we may not touch in our CKD clinics. So under something like the KCF, there's the patient activation measure score. Many of you might have seen the article that came out in the American Journal of Kidney Disease talking about how that works in end-stage renal disease. Not a lot of data, but nonetheless, that's a metric that we have for those of us that are in the KCF program starting in January 2022. Well, what better way to improve patient activation and engagement than to put them through an intensive 4-week training course? So we suspect that this is going to have a good outcome on that too as well. Getting patients to transplant earlier so that earlier transplant referrals can be there, that transplant bonus, which is very important for practices. Let's get that done. Let's make that happen. And this is a great way to do that. Possible to reduce admissions? I think this is true. There is a analysis that was done, a meta-analysis that was done recently in Kidney 360 that talked about the potential to reduce admissions and potentially reduce mortality. We don't have a great study on that, but I think a lot of us that do this feel like anecdotally we've seen reduced admissions in that peri-dialysis initiation period, where the average is about 1.4 admissions in those first 90 days. So I think this helps. From our program, we saw no fluid overload admissions in their first 90 patients through the program. ETC, same thing. You have that home therapy score. I think we can improve home therapy adoption on the back end this way. If you offer self-care, you can teach a bit of self-care as you go through the transitional care unit as well. And this offers you that opportunity to augment that home dialysis, home therapy score too as well. Again, patient navigation, you have a transplant score too as well. Getting patients to transplant is the best thing for patients. It's absolutely the best thing for us, and it's going to help the score for those of us in the ETC as well. So those are all the areas that I think make the transitional care unit a very reasonable intervention to think about implementing in your program in the background as to why we think it's an important thing to pursue in general. And with that, I'll turn it over to Dr. Taylor.
Thank you so much, Brendan. And before Dr. Taylor starts, I'd just like to have the honor of introducing him briefly. Praise Taylor completed his internal medicine residency and nephrology program at the Hospital of St. Raphael with Yale University School of Medicine in New Haven, Connecticut. He's been in clinical practice with Nephrology Associates in Newark, Delaware since 2005. He currently serves as the medical director for Fresenius Kidney Care Brandywine Home Therapies, Delaware's first standalone home dialysis unit. He's passionate about home therapies and easing the burden on patients as they transition from chronic kidney disease to end-stage kidney disease. Along with Fresenius Kidney Care, he helped design one of the country's first Transitional Start programs, which has been open since 2017. Dr. Taylor, we look forward to your presentation.
Thanks, Katie. It's a pleasure to be here. I really want to thank the organizers of this event for inviting me to speak and share my experience. So without further ado, I'll just add on to what Brendan's already laid out, which is a really nice example of the history of Transitional Start and the reasons why Transitional Start is appropriate for many patients. So one of the things that Brendan mentioned was that we still see a lot of unprepared patients starting dialysis. And while a fair amount of that is due to the fact that, these patients are either referred late or, they just can't get in to see nephrology. There's another big reason as to why patients may be unprepared, and that's fear. I know that the patients that I've seen who I've had go through educational pre-dialysis education and have them come back to the office and time again, they'll tell me, well, I don't know that I want dialysis, but we'll cross that bridge when I come to it. Or, yeah, I'm not sure what type of dialysis I want to do, but we'll save that discussion for another day. And sometimes they don't say anything. And, it was a very frustrating experience for me until I saw the other end of it after they started dialysis. And, they're almost in shock. And it took a while for me to step back to understand what these patients were going through. So Transitional Start is a great way to support your patients both physically and mentally as they start this life-changing treatment modality. So when we think about patients who would benefit from Transitional Start, it's anyone who's starting in-center hemodialysis or contemplating a modality change. So if you have patients that have a failing kidney transplant, or they're just not doing well on peritoneal dialysis, and you're thinking that it's time for modality change, well, Transitional Start may be a good option for them. If they have temporary in-center hemodialysis requirements, so these may be your own home hemodialysis patients or peritoneal dialysis patients who require hemodialysis temporarily in a center. This is a place where you could do that to provide respite care or for administration of intravenous antibiotics if it happens to be something that is being treated outside of a peritonitis. And if you have patients who have acute kidney injury, especially if they have late-stage kidney disease and they're not really expected to recover, those patients are still going to benefit from Transitional Start because they'll get the education they need to make the right decisions for themselves if they do not recover kidney function. There are some patients that really won't derive much benefit from this type of program, and those are people on hospice, very disabled patients who are permanent residents of nursing homes, or those with severe cognitive impairment or have unstable living situations. These patients may be better supported in-center. And if those things change, then you can bring them to your Transitional Start unit after that and provide them with the same education that you've given to the other patients. If you could advance the slide, Brendan. So this is a sample Transitional Care unit curriculum. There are different curricula out there. Some large dialysis organizations have specific ones that they use that are very prescriptive down to the minute of each presentation and who gives that presentation, and some are less prescriptive. But in general, I think Brendan went over kind of the things that we want to discuss with patients when they are ready and willing to listen. So some of it may seem repetitive from your pre-dialysis education, but in the pre-dialysis phase, you have to really wonder how well is your patient able to process this information, especially if they're developing uremia or they're having other complications or just worsening depression because of their kidneys failing. So Transitional Start provides the time and place to have the discussion again. And so in our unit, we started off with a 4-week curriculum, and the first week is just getting the patient settled on dialysis, easing them into the process, introducing them to the team. By the next week, we're talking more about dialysis modality education, access types, adjusting their hemodialysis prescription. And that continues through the 3rd week while we start asking the patients about their choices, while we continue to adjust the dialysis script. And by the 4th week, they're ready to graduate. We ask them what they want to do and refer them to the appropriate setting, confirming access plans for dialysis and refer for transplant. And in the rare case, some people will choose conservative management. So then we might involve palliative care or hospice. If you go on the next slide, Brendan. Well, delivering that education does take an entire team. And in the center of that team is the patient. And so we have our nurses, our patient care technicians, the dietitians, the financial coordinators, and the social workers, as well as the physician and the nurse practitioner or PA, all working together to provide this education for the patient. And over the next few slides, I'll go over what we specifically do. Next. Excuse me. So the first week, as I mentioned, is a welcome. We're just settling the patient out. They meet the entire the team, and we start talking about what the patient's concerns are. What are their fears? What are their goals? What do they enjoy in life? What do they want to get back to? And that gives us some goals to shoot for. And the entire team's aware of this. And so we all work together and try to coordinate the education and the wherewithal for the patient to be able to achieve those goals. We continue to adjust the medications and the dialysis script and initiate plans of care. Next slide. So we talk about all types of modalities, including in-center, home hemodialysis, PD, transplant, as well as conservative care, and palliative care. We continue to modify the script, making sure that we're getting rid of those multiple times a day medications that make life so hard with the pill burden that these patients have, and getting them back on appropriate therapy, which would include ACE inhibitors or ARBs for many of our patients. We start talking about permanent access options for each modality education and start educating them on vaccinations, which is even more important these days. And we start administering those vaccines. And by the 3rd week, I think patients are starting to get an idea of which way they're heading. We certainly do provide additional education for those who need it and give them the opportunity to speak to other patients who are doing dialysis so that they can get firsthand information about particular modalities. We'll refer for the permanent access creation, schedule vein mapping if that's appropriate. If someone's going to choose home hemodialysis and already has a fistula or a graft, we start educating them on self-cannulation while they're waiting for their training spot to open up. And then we call central admissions if they're going to stick within center dialysis. By the last week, they're ready to graduate. And so as in Brendan's program, they basically will transition to their chosen dialysis setting. They'll follow up with their access creation and transplant appointments. Again, it's a good time during these 4 weeks to have a discussion regarding advanced care. A lot of times these discussions have not been had at any point up until now, and now they have an organ system that's failed. So this is an exceedingly important discussion to have with your patients, and during the weeks that they're in transitional start is an entirely appropriate time to do so. So I'll talk about what does a transitional start unit look like? Well, transitional start, as Brendan has mentioned, could be considered more of a concept as opposed to an actual place or location. But that being said, you could really do transitional start in almost any dialysis unit. This is a model of a standalone transitional start unit. So you may just have 4 chairs there. And, as much as possible, we try to expose people to the home hemodialysis machinery so they really get a firsthand experience of what that's like. But it doesn't have to be a standalone unit, and you don't have to build it from the ground up. Next slide. This can be part of your home therapies unit. And in this way, the patients who are doing transitional start really get a great opportunity to see the home modalities in action. In our unit, the transitional start area is catty corner to the home hemodialysis training area. And we have big glass windows so that the patients who are doing transitional start can actually see the patients who are doing home hemodialysis. I think that's been a big boon to our home hemodialysis population because no one thinks that they can do home hemodialysis when they're starting dialysis. No one's comes in saying, yeah, I can put needles in myself, easy peasy, no problem. But when they see someone else doing it, it really gives them the courage to think that they could probably do it themselves. And then also they can see people doing peritoneal dialysis training as well. But it doesn't have to be part of a home therapies unit either. Next slide. This can be part of a combined unit where you have all modalities involved. Home therapy stations, in-center, as well as cordoning off an area for transitional start. You don't have to have a wall. Some people just, have a curtained off area where you just have new patients that are starting. And in the next slide, you can see that it could just be part of an in-center unit. So you don't have to have a massive physical structure or physical plant to do transitional start. It just has to provide an area where patients are seen in a manner in which they get a lot of attention by the entire team. The staffing ratio is important. As Brendan mentioned, the original hemodialysis orientation unit had a 1 staff member to 2 patient ratio. In our unit, we have 1 patient care technician and 1 dialysis nurse for 4 patients. And that's worked well. Next slide. So let's talk about schedules. Traditional dialysis in the center is 3 times a week. But, when we think about dialysis and the outcomes that we've seen with as per the FHN trials, I, for one, am a strong believer that more frequent dialysis is better. And so in our unit, we do a 4-day-a-week model. And, admittedly, we have our staffing challenges, as many of you do. And so currently the model is Monday, Tuesday, Thursday, and Friday. Ideally, we'd prefer to avoid that 2-day gap over the weekend. But unfortunately, right now, staffing prohibits that. But ultimately, we'd like to get to that. And you could do a 5-day-a-week model as well with shorter time. But we have to be cognizant of the fact that, during this first 30 days that patients are on dialysis, they may have a lot of other appointments. So we have to adjust for their schedule sometimes. And then the other challenges we've had with that is that sometimes physicians feel like, well, why does my patient need more frequent dialysis? They're just starting dialysis. They still urinate. Well, I will tell you that as with Brendan's experience, I have not had any patient in the last 2 years have to go to the hospital for fluid overload as they started dialysis in the first 90 days. More frequent dialysis will help us to avoid that intradialytic hypotension. It will help us to prevent cramping. It'll help us to give the patient a better experience when they initiate dialysis. Because if you start pulling tons of fluid and the patient drops their pressure and they start feeling horrible as they start dialysis, well, they're going to think horribly about this modality. And a lot of that has to do with how we prescribe. So, it took me a while, about 2 to 2.5 years, but my group finally bought into the concept that this is actually better for patients. And now every new start gets referred to our transitional start unit. Next slide. So we have we're currently using all conventional dialysis machines, but part of the goal is really to give the patient experience with home hemodialysis as well. So soon we're actually going to be transitioning to all home hemodialysis machines. But sometimes that can be cost prohibitive. And it doesn't mean that someone has to be on home hemodialysis machinery the entire 4 weeks. You could do a hybrid model. You could use conventional machines for 2 of those 4 weeks or 3 of those 4 weeks and still be able to give your patient good exposure to home hemodialysis machinery so that they can understand the difference between these 2 modalities and how they feel depending on this machinery. So once patients are kind of going down the road of home hemodialysis, we also start, taking some time for cannulation training, as I mentioned earlier, and that helps expedite their training once they move over to the home hemodialysis training area. Next slide. And that's my last slide, and I'll let Katie take it over to introduce Suzanne.
Thank you so much, Chris. Really appreciate it. Our final speaker for the afternoon is Ms. Suzanne Chabella. She's the Executive Director for MidAtlantic Nephrology Associates, which is a 50-provider nephrology group located in Baltimore, Maryland. Suzanne has over 25 years of business and healthcare management experience and is a frequent presenter at the American Society of Nephrology and at the RPA meetings. She was awarded the Distinguished Practice Manager Award by the RPA in 2015. Suzanne earned her MBA from Loyola College of Maryland and has dual Bachelor of Science degrees in both mechanical engineering and engineering administration from Michigan Tech. Suzanne, thank you so much for joining us today. And I'm a big fan of MidAtlantic Nephrology Associates and what you've done there. Look forward to hearing what you have to say.
Thank you, Dr. Kwan. And I too want to thank the RPA for putting this program together, inviting us to share our experience with transitional care in the Baltimore area. So next slide, please. So MidAtlantic Nephrology Associates is a large independent physician-owned nephrology practice. We're based in Baltimore. We deploy 38 nephrologists and 14 advanced practitioners every day. We have 10 MANA offices, and we run at 42 dialysis facilities and go to 12 hospitals. And we care for 2,500 dialysis patients and 13,000 CKD patients. We also have 2 ambulatory surgery centers where we perform vascular access procedures, and we actually have 4 trained interventional nephrologists. Right now, our home therapy penetration rate is about 11%. It is much better than it's been in the past, but it is certainly not anywhere where we want it to be or need it to be. Next slide, please. So back in 2018, we decided to do our first transitional care unit. And the purpose for this was that the physicians wanted to create a better model of care and provide this comprehensive education and support and provide a dedicated care team, both to increase the education or the patient's understanding of their disease state, as well as robust modality education. We also wanted to grow home therapies, and we thought that the TCU would give the patient a better understanding of home therapies, and it would also allow us to help them overcome any barriers that we might discover during this 4-week program. We wanted to enhance patient engagement, and we also, of course, wanted to promote optimal outpatient starts. Next slide, please. So in November of 2018, we opened our first transitional care unit. Just like Dr. Taylor showed in one of his schematics, we located it in one of our kidney home centers. So MANA actually has 3 standalone kidney home centers that do nothing but peritoneal dialysis, home hemodialysis training, and support. And so we chose to put 6 stations into our first kidney home center. And we selected the next stage machines. And that was a very thoughtful decision. We wanted this to have a different look and feel. We wanted it to look like home. We did not want it to look like an in-center unit. And so we knew it was going to be more expensive, but we made that decision. And so we run patients Monday, Tuesday, Wednesday, Friday. And the only staff that we hired to get started was an independent patient educator, patient care technician, and a nurse. We have the other team members that Dr. Taylor talked about, but we leverage those resources from the Kidney Home Center. So we use their dietitian, their social worker, and their management. And we decided, because we had never really seen a unit, we had talked to Dr. Taylor about how he had his setup. We chose to go with individual rooms. So each one of the 6 stations, excuse me, is an individual room, has walls, they're glass, we have a glass door, but there's a door that you can close. And we thought that was important for the patients to have time to do one-on-one education with the patient educator in a quiet setting. Skip forward to February of 2021, and we opened TCU number 2. It's been open about 8 months. We locate this again in a kidney home center. It's a different kidney home center. This time we go with a different model. So we have 6 stations, but we selected the Fresenius machines. And for just what Dr. Taylor had stated, the ease of staffing on Saturdays. It's hard enough to staff on a Saturday, but if you have a piece of equipment that has very limited nurses that are familiar with it, it's going to be difficult. But we wanted to compare the 2 TCUs, and there we go. We wanted to compare the 2 TCUs and look at the difference between, one that runs during the week and still has that 2-day gap, and what happens if we can get rid of that gap. Now, we don't have enough data to actually compare that because we just opened this TCU 2, but that was one of our reasons. And of course, the Fresenius machine is more economical. So right now we run patients on Monday, Wednesday, Thursday, Saturday. Again, the same independent patient educator, patient care technician, RN. However, we went with a different layout this time. We went with an open concept. And the reason was, when we opened the first transitional care unit, we actually called the state surveyors. DaVita has a relationship with them. We have a relationship, and had them come out and look at the layout of TCU1. And their first concern was line of sight. It wasn't adequate. And so they needed us to immediately have 2 patient care techs and a floating RN so that eyes could be kept on all the patients. So in the second TCU, we learned from that and we did an open concept. So it looks like cubicles, but there's nice large knee walls and glass that goes all the way to the ceiling. So they still have the privacy, but we didn't have to have that extra body to start. Our average census at each TCU is about 8 to 9 patients. Next slide, please. So here's our data. It encompasses both TCUs, and I don't know if you could see how in the tiny lower right-hand corner, but we have actually admitted 155 patients to date, and we have actually had 143 discharged from the TCUs. And you see the pie chart shows that 32% or 31.47% of patients are discharged to a home therapy. So the majority of those are obviously discharged to PD. But you can see on the fringes there that there's other reasons. I mean, we're very excited. We had 4 patients transplanted. 2 were discharged to prolonged hospitalization. Unfortunately, 1 expired. But you see there's other reasons why patients will move out of the TCU. Next slide, please. So what are some of the operational lessons that we learned? Well, leading up to the November 2018 TCU1, we spent 2 years at every meeting talking about transitional care, going through creating the curriculum. And every physician at MANA was super excited about this program, super excited. We opened the doors November 2018, not 1 referral. And the number of patients crashing into the hospital did not change. Nothing else changed. And then we discovered that changing physician behavior takes time. Physicians in the hospitals are very busy. They were doing the same old, and we just really had to ramp that up and get people to change their behavior. The second lesson we learned was there are so many places where these referrals can get screwed up. We do not have the same rule as Dr. Taylor that all new starts go through transitional care. We just don't have the infrastructure to support it. We start 400 to 500 patients a year. So we just have these 2 little TCU units. So we have these feeder hospitals, even if the physician was putting TCU in big letters on the medical record, somehow the discharge planner at the hospital would send the patient to an in-center unit. Or the dialysis side, the intake side at DaVita somehow messed up and put the patient somewhere else. So we really had to sit down and review those processes and re-educate. We felt strongly that we needed a dynamic champion physician to start this new program. We didn't know how successful it was going to be, but we made the decision to dedicate a physician 1 day a week to TCU1. And that's a big deal because you all know nephrologists are super busy. We don't have physicians sitting around with time on their hands. And so this was a big expense that we as a practice decided that's how important these programs are going forward. And I think that was a huge component of our success. The personality of the educator matters. And that was advice given to us by other physicians that have tried this prior to us. And we learned it firsthand. You can know a lot about home therapies and disease state. You can be an excellent RN, but if you can't connect with the patients when it comes to the education portion, it's not going to work. And we lost a really good educator. She relocated out of state, and we saw the impact of that immediately. Like I said, the open floor plan may provide staffing efficiencies. I think we would go with that. Next time, I was very interested that Dr. Taylor described like a hybrid. So we are going to open our next TCU early next year, and it had not occurred to me to pick one or the other or combine the two is interesting. And we did not consider accepting AKI patients. We said no to that, and that's another interesting fact. We did just recently open that up to our inclusion list, but early on, we did not want to waste chairs on patients that may recover function. But DaVita showed us some very compelling data that 50% of our AKI patients convert to ESRD. And so we have opened it up to AKI patients. And what we did find out is that educated patients make better patients regardless of where they go. We have been getting great feedback from the in-center hemodialysis units that these patients are more compliant, they're more engaged in their care, and they understand what's going on. Next slide, please. So from the business side and the financial side, we bill for 4 treatments, but only based on medical necessity. So if there is no medical necessity, we bill for 3 treatments. Medicare has a standard list of what qualifies for medical necessity. And our payer mix tends to run higher at TCUs. We're not quite sure why. Could be that working professionals crash into the system and have commercial insurance, or it could be it's just such a small number that if you even have 1 or 2 commercial patients, your payer mix is impacted. Of course, the expenses are lower for the Fresenius machines versus the next stage, everybody knows. And the bottom line is we cover our costs with a very small margin. You would not go into the business of transitional care for the return on investment immediately. You wouldn't, it's just not financially viable. And cost allocation really plays a critical role here because just like Dr. Taylor showed, you have these different schematics. And how do you allocate the cost to those 3 chairs over in the corner, those 6 stations over on the side? How do you allocate the rent? How do you allocate the leadership if you're sharing it between the units? So cost allocation assumptions are critical if you really want to know what the bottom line is if you're losing money. But we all know the goal here is to have better educated patients who are well informed about home therapies. I mean, the goal is not to make a ton of money on this. The goal is to have better educated patients. And of course, just like Dr. Bowman said, it creates downstream gains under the new CMS payment models, both for the individual nephrologist and at the facility level. So with that said, I will turn it back over to Dr. Kwan.
Thanks very much. I'm going to ask for all of our panelists now to turn on their cameras and unmute themselves if they want to talk. And we have about 10 minutes left for questions. I've learned a lot. I'm excited at the thought of maybe getting this started in my own market. I'm thinking about a lot of the patients that start on dialysis, and they're often pretty uremic. And I'm not sure that the first week or two on dialysis that they're hearing much of what I have to say. How do you all approach that? It seems like a 4-week curriculum. You have a lot of information to deliver. Are they ready to hear it from week one?
I'll take the first cut, and then you all can add. I think one of the things, I think it's, as Dr. Taylor laid out, that first week is really settle folks in, get them comfortable, address any of the immediate medical concerns down there. One of the advantages that I think, Prayas alluded to is with that 4-day schedule, you have an opportunity for break days and catch-up days. And in fact, we kind of mandate that you don't really do anything more than 30 or 40 minutes of kind of bedside teaching a day. We know people just don't handle that. So you have opportunities to go back. There's it's a very soft, flexible schedule. And so you're able to kind of, move that around. It's really probably about more than 2.5, 3 weeks worth of teaching, I think, altogether when you look at what you're doing in those 4 weeks. And so that's how we think about it.
Yeah, I've had the experience of seeing people, fairly closely as they get started. And yeah, usually after 3 or 4 treatments, they're feeling a lot better. They're more comfortable with dialysis as a modality itself. And I have really seen that they're willing to listen at that point. Much more receptive, after that 4th treatment, I think.
Yeah, our experience, excuse me, is the same, and it really has to be individualized to the patient. So there are some patients that are medically stabilized more quickly than others and are more receptive to the information. But on an individual level, it could be stretched out. They may not be ready.
Fantastic. Thanks. We have some great questions coming in from the audience. I love that all of you are willing to share your data on your outcomes and appreciated seeing that. But one question is, what's been the persistence of home modality choice after they've gone through TCU? So what are your percentages looking like 1 year out?
That is a very good question. I'm sorry. Dr. Taylor, you want to go ahead?
No, go ahead, Suzanne.
So we are looking at that. Our gold standard is going to be what percentage of our patients are still on the therapy after 6 months. We are getting our hands around that data right now with the help from DaVita. But initially, when we started the program, we saw 50%, 60% choosing modalities. They certainly never got through the training process. I mean, we think the 32% is a much more realistic level, but we don't have the firm data yet. We just started collecting that 6 months out.
We've had, so we have a unit that's probably running anywhere between 150 and 160 home dialysis patients, and probably about 8 to 9, 8 transitional start unit patients at any given time. So, historically speaking, in order to maintain your peritoneal dialysis population, some of us may have heard this. I mean, you're going to have about a 20 to 30% attrition rate per year. And so we've been able to maintain and grow with our transitional start unit. So I think that what I'm seeing is that many of them will stay on. I will tell you that we've had people who have done peritoneal dialysis after transitional start and just did not like it. And then we basically switched them to home hemo, brought them back into the transitional start unit for a short stint, and then moved them over to home hemodialysis training, and they've gone to that modality. So I think the question is a good one. I think there's still a need to get more data to know what's happening, but there's different ways that can kind of play out. We're also seeing people who choose in-center. 3 months down the road, they're back training for home dialysis.
All right, a lot of questions coming in, and we often have a chance to do follow-ups afterwards, but we have a few more minutes. One question I had was that traditionally we know that folks who chose home dialysis tend to be whiter and better off than the general ESKD population. So there's been some historical disparities towards care. I don't think that there's much data on this, but anecdotally, does the TCU play a role in addressing some of those disparities and inequalities?
Yeah, I think your point's a great one. So everybody's familiar with the data in terms of access to transplant, access to home dialysis, certainly in the pre-SKD population. We didn't show that slide from USRDS. That does show that, disparity in care. But we think by having this kind of checklist approach where everyone gets an opportunity down there and fairly intensive personalized teaching, that there is an opportunity to close gaps in pre-dialysis disparities. For example, early on, week 1, you're talking about transplant, or at least assessing, has this individual been referred already? If not, why not? If not, we're on it, and taking care of those things. So you're probably not going to close all the consequences of the lack of upstream education in some cases, but I think it can be an opportunity to do that if it's done correctly. We haven't looked at our own data. Our dialysis population is over half minority already, so that's kind of the area we play on. So it's a little tough to do that. But anecdotally, I think in terms of choosing home therapies, we see a pretty even spread among all groups.
Thank you so much. We're getting a lot of questions about the TCU staff, and I think Suzanne spoke how much it's important to pick the right people. So are your TCU staff also the people that do the training when people decide to do in-center? Do they do both peritoneal and home hemo? And then additionally, you mentioned that working patients and private pay patients are maybe a little overrepresented. So are you able to staff for an evening shift so that these people can continue to work?
So our staff, we do not use PD nurses or HHD nurses to do the education. We were most successful with a patient care technician who just had a real dynamic personality, who was fully informed about the home modalities. And so we don't use, we are in the kidney home center. So we can very easily just talk across the aisle there and say, can we have a PD nurse come over and talk to the patient? Can we have an HHD nurse? Or they can also talk to other patients that are in that modality. But from a staffing perspective, the educator does not have to be, I would say you could use a patient care tech, an RN, a social worker, but it's that personality and the ability to teach others.
I would say I totally agree with what Suzanne said. We have a very dynamic educator who we used in the chronic kidney disease space, and she is actually a kidney care advocate for Fresenius, and she does a lot of our education. But don't discount your patients. They are the ones who can sometimes provide the best education for another patient. So one of the things we've tried to do now is start to develop a panel of patient advocates, people who are willing to talk about their experiences. And then, if you have a particular patient who, let's say that they're a mother, a working mother, and you might want to hook them up with someone who has, is also a mother on dialysis, so that they have some shared experiences they can draw upon. And that's worked out pretty well. We're trying to build that up more and offer it even via Zoom after hours, so that, we do realize people are working. So some of this education can be delivered by your staff after hours or by other patients after hours. Just got to set it up.
I think we have about 1 minute left, and we have a lot of great questions. Does the TCU experience result in patients who are more compliant with dialysis long-term, regardless of which modality they choose?
Absolutely. We've gotten that feedback from in-center units directly to our medical director, and they are amazed at how better compliant patients they are in the in-center unit, for sure.
All right, I think we are at 2 o'clock, so I want to pass it to Amy to see if she has got anything else for us. Thank you, everybody, for attending. Thank you to Dr. Bowman, Dr. Taylor, and Ms. Shabella. Really appreciate having you all here for us, teaching us today.
And I would like to thank Dr. Kwan and all of our panelists today for this very informative session. We did record today's session and it will be available on e-learning. We'll also get the slides out to all of you. And please check the RPA website for future webinars. So thank you all again for your time today. And we will do our best to go through the remaining questions and get answers out. Again, thank you. And that concludes today's webinar.
Bye. Thanks, everyone.
Have a great weekend.